This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hey, this is Jason Crowell from Norton Neuroscience Institute in Louisville, Kentucky. Thanks for listening to today's Neurology podcast. Today, it's my pleasure to welcome Jake Elberg to the podcast. Jake is an associate professor of law at Seton Hall University, and he is the director of their Center for Health and Pharmaceutical Law. Jake, thanks for joining us today.
Thanks so much for having me.
So we are covering a topic that I spoke with Ed Silverman of Stat News about back in 2020. For our longer term listeners, you'll remember this podcast from February 10th, 2020. We talked about some allegations that were made against certain drug makers. So at that time, there were some drug companies producing drugs for multiple sclerosis that were allegedly involved in a kickback program with a variety of patient assistance organizations. And so we're going to talk about an article that Jake and his co-authors recently wrote and that was published on that same topic. So this was published June 29th in the New England Journal of Medicine. It's a perspective piece. The title of this article is Patient Assistance Programs, Kickbacks, and the Courts. So Jake, let's give kind of an overview. Can you summarize for us what exactly is the relationship between these different actors? So there's patients who are trying to get a drug, there are drug makers who are trying to sell a drug, and then there are these patient assistance organizations in the middle. What's the relationship between these different groups?
The relationship and determining what that relationship should be and is allowed to be is really at the heart of the government enforcement here. So patients, of course, have to pay for drugs and even patients that are covered by Medicare, where Medicare will cover the vast majority of the cost of drugs, it still leaves, in many cases, substantial cost for patients. And so whether those come in the forms of co-pays or other sorts of payments, patients left with often really substantial payments that create a burden and frequently an insurmountable burden for patients. And so as a result of that, what have sprung up are patient assistance programs. And those are charities that are designed to help patients with that. And whether it be obtaining drugs for free or helping them obtain discounts on those or other ways to pay for those co-payments, that helps patients deal with those burdens. The question then arises is what connection is legitimate and allowed between the manufacturers and those charity programs. Nothing wrong with manufacturers saying, hey, we're going to give our drugs away for free to patients who need it and can't afford it. But where those drug companies are seen as essentially eliminating or reducing that government copay, that's viewed as a kickback and in violation of the anti-kickback statute.
So to make sure I understand this, so if I'm a drug maker and I'm donating money to these assistance programs, and the assistance programs takes that money and pays the copay for a patient, then essentially I'm getting the benefit of that larger payment from the insurer, i.e. the government, for the small cost of having to contribute to the patient's copay. Is that right?
That's right. And interestingly enough, and part of what makes this a challenging issue, it's okay for companies to be the manufacturers, to be donating to these charities, even if the charities are then going to use some of that money for that purpose. What's not okay is for the companies to be doing that with that in mind. And so what makes these cases challenging is really looking into those relationships, and where problems arise are frequently the situations where the companies know frequently explicitly, well, if we give X dollars to this charity, Y dollars are going to go to patients using our products and to make it easier for patients to buy our products specifically.
And that's really one of the aspects of this that's never been quite clear to me. Specifically, again, if I'm a drug company and I give this money to an organization, how can I be sure that I would get that money back? How would I be sure that that money would be used to pay for the copay for my drug? Right. So, take Alzheimer's disease, which we see patients for. There's only one, now two drugs that have a disease modifying benefit. And so if you gave money to an Alzheimer's patient organization, then you have a pretty good expectation that, well, if they're going to use it for copays, it's either going to be for my drug or the other one. But, in MS, for example, we've got lots and lots of drugs. So how could a drug company know that they would see that money returned to them specifically in the terms of patient assistance?
So that's what really comes back to what's the relationship and what are the communications between the manufacturer and that charity. And putting my old prosecutor hat back on, I worked for the Department of Justice before becoming a professor. Finding evidence of what those relationships are is what can be really challenging. And what you see in the cases that the government has brought most frequently is evidence where they're actually sharing information about specifically what you raised, Jason, specifically raising information about what kind of money is going to go in the one direction and then how much of that is going to go to their patient specifically.
With the idea being that when that's spelled out, it becomes quite clearly a quid pro quo and you're doing this for that. Is that right?
Exactly. And beyond that it's really then making the charity be a pass-through, right? It wouldn't be okay for the manufacturer to say to patients, hey, we'll give you money for the copay, since that will be coming right back to us anyway, and therefore we'll get all the money from the government. Well, you can't do that through the charity either as a pass-through. And so where the relationship allows that to be essentially spelled out, the closer that comes to happening, the more problem the relationship.
So can you summarize for us some of the recent lawsuits that have been brought that have helped clarify the legality or the lack thereof of these assistance programs?
What we see in some of those cases, and interestingly, we see cases from the government brought not only against manufacturers, but in some cases against the charities. And what we see in those cases most frequently are situations where, for example, you'll have somebody from the manufacturer and somebody from the charity, and they're actually sharing information, sharing spreadsheets or bottom line numbers of this is the amount of money we expect we're going to get in requests from patients, or that we have gotten recently in requests from patients dealing with your drug, or this is how much money we've been sending out to patients for copays for your drug. And if you give us X dollars, that's what we'll be able to do with it.
One of the aspects of this topic that you mentioned in your paper is how the Inflation Reduction Act comes into play here. So my understanding is the Inflation Reduction Act is supposed to address out-of-pocket Part D Medicare costs by setting a maximum out-of-pocket limit. I think it's $2,000. And so that's great if we view the problem as seniors' ability to afford the medicine, right? So that should address that problem by capping their out-of-pocket cost. But then doesn't this also insulate the exposure that drug companies face with respect to the market forces, right? So if patients are not bearing this cost, then what prevents a drug company from raising the prices higher?
There are a couple of issues there. So first of all, I think what we're seeing here really drives home the reality that for a lot of patients, that $2,000 is a lot of money. That when we're thinking about older patients, patients who aren't working, patients with really limited income, that $2,000 may itself be insurmountable. And so while you're exactly right, Jason, major big deal having that $2,000 cap that really reduces the problem for a lot of patients in terms of the cost of drugs. It doesn't eliminate it. And the fact that we've seen manufacturers push this issue even after that was passed really shows that the issue doesn't go away. That $2,000 cap doesn't eliminate the issue, and that manufacturers are still concerned we're going to have patients not buying our product because they're going to have to pay that money, even with that $2,000 cap. And that concern, to be clear, has a couple of parts to it, right? One, that everyone, I think, would share the idea of having patients who really need the drug and aren't going to get it. I think it is fair to believe that manufacturers are being sincere when they express being concerned about that and wanting that not to happen. The second is something that I think manufacturers are concerned about and others maybe aren't, which is the idea of them losing the business and not getting the money from the government there. So the issues are still there even with the $2,000 cap. You're right, Jason, to raise the issue, and it's part of what we raise in the article about the insulation. There are a few different reasons from the government's perspective for requiring copays. And one of them is to try to make sure that folks are only using products that they really need and those sort of things. But that's really not the issue here. That's not really so much what we're talking about. Here, the issue is more making sure that there's not just a total disconnect between individual patients out there and people living out in the world and drug prices. So drug prices don't become something that only pharmaceutical companies and government bureaucrats are thinking about and patients don't see. And so by having those copays there's a sense to which society can still be tracking, still have a sense of, boy, these drugs are really expensive. Are we okay with that or not?
So if I understand it correctly, lawsuits have been raised in regards to this practice, but it is still permissible for drug companies to donate this money to assistance programs, and it's still permissible for assistance programs to assist patients. But basically, these lawsuits have clarified that it can't become a quid pro quo situation. These assistance programs cannot merely be a pass-through for the money.
Exactly. And interestingly, there are lawsuits going in both directions. So we've seen government enforcement where the government has come in and brought lawsuits and settled lawsuits and collected lots of money for violations here. But what we've seen most recently, when I mentioned earlier the idea of companies pressing this issue, what we've seen most recently is manufacturers in a couple of instances filing declaratory judgment actions, which is where they go to court. The government hasn't brought any enforcement action, but these manufacturers are going to court and saying, hey, court, agree with us that we should be allowed to do this thing we want to do, and that if we go and do this, the government shouldn't be allowed to give us a hard time about it. And so part of that is seeking clarification, but part of that is beyond that is trying to change where that line. That being said, there's no dispute from the government that it's okay for companies to be donating to charities, that it's okay for charities to be helping patients. The question and where the fight is has to do with where that line's going to be in terms of what kind of communications, what kind of information manufacturers can be sharing back and forth with charities that they are donating to.
It kind of makes me wonder, like we talked about earlier, I wonder if drug makers are more likely to pursue their ability to donate to assistance programs for diseases where there's lots of competition as opposed to a disease where there's limited competition, because it kind of tests that hypothesis of their likelihood of seeing the return on their investment, so to speak, if there's more competitors that they might be fighting against versus if there's only one or two competitors. Just kind of thinking out loud.
I do think it's important to remember that the only issue isn't competition. They're not only fighting against competitors, they're also fighting against patients deciding not to get the drug at all, whether to just go a different route in terms of treatment or to go without a drug that they may need to varying degrees. And so part of actually where we've seen the manufacturers press this issue is exactly that situation, Jason, that you suggest, is where there's not competition there. We're talking only about the issue of affordability for patients. And the government's position right now is still, even in that situation, the government is still concerned about it. But manufacturers are still very anxious to try to essentially insulate patients from copays, even where they don't have competition from other manufacturers.
Well, great. Thanks for explaining this to us and joining us and shedding some light on the issue. I encourage our audience to check out the article. Again, it was published as a perspective piece in the New England Journal of Medicine on June 29th. Again, the title is Patient Assistance Programs, Kickbacks, and the Courts. And once again, I've been speaking with Jake Elberg from Seton Hall. Jake, thanks for joining us today. Really appreciate it.
Thanks so much for having me, Jason.
This is Stacey Clardy, your podcast editor. Thank you for listening and for letting us join you on your commute, while you're exercising, or even while you're brushing your teeth. This has been another episode of the Neurology Podcast, your best source of practical, relevant, and timely information for neurologists, clinicians, and patients.